Dawson.
Good morning, my lady. The first witness this morning is Professor Mark Woolhouse, OBE.
We meet again.
If you'd like to stand, please, and repeat after me. I do solemnly, sincerely and truly.
I do solemnly, sincerely and truly.
Declare and affirm.
Declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
Nothing but the truth.
Thank you.
You are Professor Mark Woolhouse.
I am.
You have helpfully provided a statement to this module of the inquiry along with other statements provided to previous modules. Your modular statement for this inquiry is dated the 14th of December 2023 and has the reference INQ 000369765. Is that your statement?
It is.
Do the contents of this statement remain true and accurate as of today's date?
They do, though we have sent a handful of further exhibits to the inquiry, but I don't think they materially affect this statement.
Thank you very much indeed. You're a Professor of Infectious Disease Epidemiology at the University of Edinburgh.
I am.
You sat during the course of the pandemic on the body called SPIMO between January 2020 and early 2022.
That's correct.
You're also a member of a group about whom we have heard evidence, the Scottish COVID Advisory Group, from March 2020. You attended that group regularly, apart from a 2-month absence from meetings in February and March 2021.
That's correct.
You did not attend the SAGE meetings that we've heard about.
I did not.
Thank you. You were awarded an OBE in 2002 for service to the control of infectious diseases.
I was.
You're a Fellow of the Royal Society of Edinburgh.
I am.
Of the Academy of Medical Sciences and the African Academy of Sciences.
I am.
We've heard some evidence about your role in providing early information and advice to the Scottish Government, in particular through Dr. Catherine Calderwood, the then Chief Medical Officer. You've given some evidence about that to the inquiry already, but I'd like to ask you some more questions in the particularly Scottish context of this module. Could we have, please, up on screen INQ 000352450? If we could go to, yes, that's the right one. This is a chain of emails which you have helpfully produced to the inquiry between yourself and Catherine Calderwood, is that correct?
It is.
And I understand that you first contacted Dr. Calderwood in connection with your concerns about the emergence of a new virus on the 21st of January 2020, is that right?
It is.
What prompted you to contact Dr. Calderwood specifically at that time?
This seemed to be a matter that very quickly would require the Scottish Government to engage with. And since I wasn't at the time part of any formal advisory system, it seemed to me the logical route to channeling my concerns to the government was through the Chief Medical Officer for Scotland.
And presumably, given the fact that you, as well as having contact with people at a UK level, contacted the Chief Medical Officer for Scotland, you were under the impression that the Scottish Government had the ability to do something about this? Yes. Health and indeed public health are matters devolved to the competence of the Scottish Parliament and hence the Scottish Government.
Indeed.
We've looked at some of the text of these emails before. I think the context, please correct me if I'm wrong, of this email is that it follows on from an announcement of recognised human-to-human transmission of the virus the previous day. Is that right?
That's right.
What was the significance of the emergence of that piece of information about the virus? We
already knew about cases of what was then actually called Wuhan pneumonia in those very early stages. And there was the possibility that these had been acquired from an animal source, a non-human source. And it is possible, there are many diseases like this, that the infection would spread from the animal, but could not then spread from person to person. So a human is a dead end from the virus's point of view. Now, that doesn't mean it's not serious. Some of these sorts of infections, like rabies, for example, around the world, are very serious. But nonetheless, that kind of infection would not cause a pandemic.
So the evidence which had emerged the day before about human-to-human transmission was a significant piece of information which would affect your assessment of the likelihood of the virus transmitting and potentially reaching epidemic or pandemic proportions.
Well, yes, but it confirmed my fears. I had already received, I think on January the 9th or 10th, a report from, that was sent to me unexpectedly, of the Wuhan Municipal Health Authority that already was describing that this was quite a sizable outbreak and had been persisting for some weeks. So I was already thinking this is unlikely to be just an animal origin epidemic, as in the only cause of human infections is from animal sources. It was already, so I was expecting this news that it was human-to-human transmissible. I'd feared that for over a week, 10 days.
I see. So this very recent piece of evidence about human-to-human transmission had added to and confirmed your fears about previous information which had been made available to you earlier that month. Correct.
I thought we were going to have a pandemic, or it was very likely that we would have a pandemic from round about January the 10th.
Thank you. You say, it's on the second page of the page we have here in the second paragraph, there are some instructive parallels with the H1N1 pandemic in 2009 to 10. Indeed, one possibility is that this could turn out to be quite similar in some key respects, a widespread epidemic fueled by mild cases, but with mortality among vulnerable patients. Can you tell us why it was that you were seeking to draw to Dr. Calderwood's attention parallels with the 2009-10 H1N1 pandemic and the various features which you identified as being a possibility of the pandemic which you were predicting for the novel coronavirus at that time?
I think that was the most instructive parallel available. And it wasn't just the characteristics of the infection, which, as the inquiry has heard a lot of evidence for, turned out to be significantly different from influenza, but also the nature of the response. And I had been involved in the Scottish response to the H1N1 pandemic in 2009. And there were deficiencies in the response at that time, and I was very anxious that history didn't repeat itself.
Yes, I think we'll get to that very expression that you used in one of these messages. But what was it about the information that you had that suggested that it would be an epidemic fueled by mild cases with mortality amongst vulnerable patients?
It's a respiratory infection, and that's pretty standard textbook expectation for a respiratory infection.
As far as the ability to detect the spread and therefore significance of the virus, what is the significance of the fact that it would be fueled by mild cases?
That simply means that it would be very difficult to track by detecting people with reporting with symptoms. You wouldn't see a lot of the cases, so you would need other ways of identifying those cases. Because they wouldn't know they were cases.
Yes, so people would have mild symptoms that they wouldn't necessarily associate as anything out of the ordinary, and therefore might not report for testing, such that chains of transmission might go undetected. Is that the broad idea?
Yes, and as you may want to discuss later, that turned out to be a huge problem.
Yes, indeed. At the moment, I'm focusing on what it was you were predicting. You're also predicting mortality amongst vulnerable patients as being a feature of a respiratory virus of this nature, based on your extensive experience.
Yeah.
You say, although in that paragraph you are pitching your prediction as a possibility, in the previous paragraph, based on the not unexpected announcement, as you've explained, of human-to-human transmission, you state that this will become a pandemic and therefore will affect Scotland. That was your position at the time?
Yes.
And that was why you wanted to bring this to the attention of the Scottish Government through the Chief Medical Officer?
Absolutely.
Thank you. Could I just then go to the next paragraph where you highlight, in light of your predictions and the particular features of the prediction you're making, what it is you think will need to be done to try to cope with this. You say such an epidemic would be difficult to track. As in 2009-10, what would be needed is an integrated surveillance setup that combines clinical surveillance, genomic surveillance and serological surveillance, the latter requiring an appropriate test. We, and I am sure many others, are working on this already. This should be unexceptionable. My reason for writing now is to emphasise that based on experience of 2009-10, that system needs to be put in place in advance of the arrival of the virus, so the sooner the better. If we wait until after the virus has arrived, then we will miss information of public health value, and our efforts to prevent the control of the pandemic will be compromised. So the message you were trying to convey was based on your previous experience of what you considered to be similar viral outbreaks. One needed to act fast in order to try to keep the spread under control. Correct. Can you help us a little bit with the requirement for clinical surveillance, genomic surveillance and serological surveillance? What would those different components have been aimed towards achieving?
So I'm actually taking this straight from what my team did in 2009, 2010 on behalf of the Scottish Government. They asked us to do this eventually. And that's the work that we did. There is a clinical surveillance system, not just in Scotland, but more widely, for influenza-like illnesses, respiratory infections, essentially. That's useful, but what we'd found in 2009 was it wasn't extensive enough. And what we were able to do, working with colleagues in Health Protection Scotland, was get that role. It's based around general practices. And we got that scaled up very quickly, and that provided very useful information quickly during 2009. Genomic surveillance, well, I don't know how much evidence the inquiry's heard about the value of whole genome sequencing. It wasn't something that Scotland actually was geared up to do in 2009. So, again, my team, we had to introduce that. It was relatively new technology at the time. We had to introduce that into the process, and that was extraordinarily valuable, just as it was with COVID-19, but not nearly as advanced at that time. And serological surveillance, and that's, again, what we did in 2009, it's basically detecting people who have antibodies to infection. So it's tracking an infection by taking blood samples and detecting who has had the infection. So it's not the same as the PCR tests and the lateral flow tests that came along with COVID. And in this, I didn't anticipate those, but it was a very useful tool in 2009, this serological surveillance. And
obviously, as you said, you were seeking to convey a sense of urgency about the need to create these systems and develop these systems specific to COVID. What was your understanding of Scotland's ability to do that at that point?
So prior to this chain of emails, I'd been in touch with my colleague Chris Robertson at Health Protection Scotland, and through him with Jim McMenamin, who I believe you've already heard from.
That's right.
And so I was getting a sense of what level of activity was going on in Scotland, and I didn't get the impression that it was, in my view, treating this situation with the seriousness or the urgency that I felt it needed.
I see. So did that apply simply to the reaction to the information that was emerging, but also to the practical requirements that you were recommending needed to be put in place in order to deal with that threat?
Yes. So in a perfect world, I would, in this email, be pushing at an open door. And the reply I would get to that email was, "Thank you, Professor Woolhouse, we're already doing this." And I believe you heard from Gregor Smith earlier, and I watched his testimony, and he said, and I'm paraphrasing slightly, Professor Woolhouse is just telling us textbook stuff. We know this. And he's absolutely right.
Right.
I was. But the textbook stuff needs to be acted on.
Yes.
And the thing that I was particularly concerned about was, although I'm very well aware of all the systems in place in Scotland and elsewhere to respond to an outbreak, including an influenza outbreak, I was already convinced at this early stage that this was going to be considerably worse. And so I was really trying to push this. But I would have been very happy with the response to this email saying, thank you, we are already doing this.
Right. And you say this was your impression. I think from various materials, including your book, you were also in contact with other people in the UK at this time. You've mentioned Chris Robertson, you mentioned Neil Ferguson, Jeremy Farrar, and others, some in Scotland, I think, with whom you were discussing these matters around this time. Were they of a similar view to you? Was there a consensus?
Oh yes, absolutely, absolutely, no question. We were all very concerned
yes.
At this point. All those people you've mentioned there.
So lest it be suggested that this was simply your view, this was a view which you had discussed and developed along with other experts in the field.
Yes.
You say in your statement at paragraph 186 that better surveillance coupled with genomic studies would have facilitated better advice and better decision-making during this crucial period. Had these systems been ramped up in late January and into February, as you had advocated, would this have been early enough to allow for the spread of the virus to have been restricted more than it was before the lockdown was imposed eventually in March?
Yes, so I'm suggesting a programme of gathering data, gathering information. There's a whole, obviously, another rather important layer of what you then do on the basis of that information. But obviously, if we have better information, we are better informed, we can make better decisions, which might well have the consequence that you outlined. But I'm here concerned with getting the information.
Of course. There is a theme, I think, which we've discussed with some other witnesses that runs throughout the testimony and the many documents you've provided, which is a frustration which I think you held and predated this period, and indeed had been the subject of some correspondence with Dr. Calderwood in the years prior to this, about the lack of data access for those like yourself in the research community in order to be able to provide the level of assistance, support, input that you would have liked to have provided in a situation like this. Could you tell us what the background to that was broadly, and whether these frustrations remained active at this time?
Well, the second point, the answer is a simple yes. The first point, that emerges again from experience in Scotland of 2009-2010 influenza. And you mentioned I was a fellow of the Royal Society of Edinburgh. We did a post hoc report of the management of that incident in Scotland, and we made a series of recommendations precisely about this, that we needed to have the mechanisms of obtaining, sharing and analysing data in place, ready to go should another pandemic arise. Quite a detailed report. And I already was aware that this report had not really been acted on, so that's one of the things about my frustration. What I wanted to know, what I wanted to happen here, me and others through the Royal Society of Edinburgh had recommended over 10 years ago. Mm-hmm. No, not quite 10 years, sorry, 2011, 12. So
right.
Getting on for 10 years ago.
Right.
And it hadn't happened, hence the frustration.
I see. We heard some evidence from other witnesses, including we heard evidence together from two Health Protection Scotland witnesses. You mentioned Dr. McMenamin, I think, and we also heard from Professor Nick Finn, who spoke, although he wasn't in Scotland at this time, spoke on behalf of Health Protection Scotland. And when they described their attitudes over this period, both, if I recall correctly, were keen to emphasise that the previous swine flu experience was a substantial factor in their thinking about the threat, but perhaps in the opposite way to the way in which you were using your experience of previous viral outbreaks. You were drawing on your previous experience, which led to you, I think, suggesting this was a significant threat, whereas it seemed that their evidence was to the effect that the swine flu outbreak was something that was making them more cautious about coming to the conclusion that this was a significant threat. I wonder if you could comment on that and whether the attitude, as I've characterised it from them, was a prevalent one at the time?
It was, and the reason is fairly straightforward, actually. In the swine flu turned out to be, by the standards of these respiratory infections, really quite benign. Its case fatality rate, the fraction of people who are infected and die, was somewhere in the order of 1 in 1,000, which is low. I mean, obviously it's significant. It's a public health problem and needed to be managed, but it's relatively low. The early estimates of the infection fatality rate for this virus were, I think that comes later in this email chain, somewhere in the order of 4%. Mm-hmm. Well, that's 40 times higher. So you can immediately see that this potentially then is going to be an enormously greater event. The reason why I personally, unlike my colleagues you've mentioned, leant towards the more concerning or alarming figure, because we knew, again, going back from certainly the first half of January, well before this, from genome sequencing studies done on material from China, that this virus was extremely close related to the SARS-1 coronavirus. That had a case fatality rate of 10%.
Right.
So from my point of view, we're in this territory. This is a very, very similar virus to something that had a case fatality rate of 10%. That's a completely different magnitude of problem than swine flu.
Yes.
That's why I...
So you are bringing together, I think it's fair to say, a number of different experiences of previous viral threats, swine flu, H1N1, and the information that you had, the original SARS, as you've just outlined, with its high infection fatality rate. Your view, bringing all of this evidence together, was not that there was evidence suggesting that this was not a matter for concern, very much the opposite. It was a matter of significant concern.
Very much the opposite, yeah.
Okay, thank you. You mention in your email the possibility that there could be mortality amongst vulnerable patients. We've heard significant evidence in this and other modules about the fact that Scotland, relative to other parts of the United Kingdom, had a relatively elderly population with significant health inequalities and comorbidities. Was it therefore all the more necessary, given this possibility of mortality against that background, to start to consider doing something to protect that large cohort of vulnerable patients in Scotland? Yes.
I wouldn't want to overstate my level of understanding of the situation at this very early stage. And we still hadn't, there still wasn't good evidence as to what a vulnerable patient was for this. There were indications from previous experiences with SARS and indeed influenza, so we had some idea, but this was all quite uncertain at that stage. But that, as I said, seemed to be the most likely course this would take.
But if that possibility did eventuate, that would be a particular problem for the particular characteristics of Scottish society, given the pre-existing...
I would not pretend to you that I was thinking at the time that Scotland was particularly vulnerable to this, just that Scotland was vulnerable to this, full stop.
Did that start to become part of your thinking over the subsequent months?
Yes. I mean, it depends what you compare Scotland with, but yes. The vulnerabilities of one thing, the main vulnerability, as you well know, is age. So the very fact that the whole UK population is actually quite elderly by global standards was a concern.
Yes, indeed. Thank you. A number of these emails, if we could scroll up through the emails, we can see the reply, scroll backwards, if you like, through the emails. You can see the reply from Dr. Calderwood, where broadly she says to you that she acknowledges your email and I think tells you that PHE and HPS, as it was at that time, before the advent of PHS, were actively considering the detailed surveillance needs and investigation required for this novel virus, and apparently recognising the value of those surveillance systems. How did you take that response? Were you satisfied that it sounded like they had things under control, or were you expecting a little more given what you had said in your earlier email?
I don't regard actively considering as sufficient.
Thank you. If we go again back through the previous emails, we're going to one on page 4, which is dated the 25th of January. And you say, you write to Dr. Calderwood again, and you indicate there that you have discussed the matter with a number of others, including Jeremy Farrar, Neil Ferguson, as I said, and that they had independently reached the same conclusions and have advised Chris Whitty accordingly. You provide some further information and then state that based on the case fatality rate, I think the infection fatality or case fatality rate you mentioned a moment ago of 4%, if you were to put those numbers into an epidemiological model for Scotland and many other countries, you would likely predict that over about a year, at least half the population will become infected. The gross mortality rate will triple more at the epidemic peak, and the health system will become completely overwhelmed. We can formalise those predictions, and there are many caveats to them, but those are the ballpark numbers based on information from the WHO. Please note, this is not a worst-case scenario. This is based on WHO's central estimates and currently available evidence. The worst-case scenario is considerably worse. Again, what were you trying to convey to Dr. Calderwood, again, about that you're developing understanding, your conversations with others, and information that seems to have developed in the days since you last wrote a few days before?
Yes. So the work that the actual science that we've started to do is at this stage, at this early stage, is trying to understand, in context of my team's work, the scale of the threat to Scotland. And I'm reporting on what we now assess the scale of the threat to Scotland to be.
Yes. And you, in a couple of lines down, you say, your reply to my earlier email did not give any indication that here in Scotland we're preparing for an R02 CF 0.04 event, and I don't have the sense that we are from my networks here either. So I think they are conveying the information that the case fatality rate is 4%, as you said earlier, which is an alarming case fatality rate. Is that right?
Correct.
And that the R being 2, that is the R0 of the virus, which is an indicator of its transmissibility. Is that correct?
Yes, and actually that one turned out to be an underestimate. So
yeah, indeed. but even with those numbers,
yes.
You are expressing there, as you've told us in your evidence, a degree of dissatisfaction with the level of the urgency within Scottish Government.
Yes, and again we come back to Gregor's comment that this is textbook. Yeah, it's textbook. My undergraduates could do this calculation.
Yes.
My undergraduates could come up with this assessment. This is not difficult.
Yeah. Well, one might say that that makes the lack of action all the more questionable and perhaps culpable.
I think I better leave that to the inquiry.
Okay, thank you. But in any event, you were, as I say, trying to convey, applying basic epidemiology, if that's correct, to the specific characteristics that had emerged from the science, the R0 and the case fatality rate. To you, it was fairly obvious that this was going to be a huge problem.
Yes, and you mentioned the book I wrote. One of the things I put in that as the final explanation in my mind for why this wasn't landing in Scotland or elsewhere was you put all this very, as I say, fairly basic information together, and what you get is an unfolding catastrophe. And I think a lot of people simply couldn't get their heads around that.
Right.
Even though, as I say, this is very simple.
Mm-hmm.
So you add this number and this number and this number and this number, and you get a catastrophe. I think they couldn't take that final step.
Yes.
Put all this information together and what's going to happen. And of course,
I think, therefore, you're attributing to the medical advisors of the government at least the ability to do the basic epidemiology and arithmetic. But are you suggesting that perhaps, given the number that came up with, they rather froze?
Yes.
Thank you. Could we look at go further back to page 2, please? This is a further email which you sent on the 26th of January, so that the very next day. Just while we're getting that, one thing that was mentioned yesterday by Professor Sridhar that I just wanted to ask you about, a couple of things about the way in which information is communicated to people like yourself. She mentioned something called PubMed, which, as I understand it, is a source of information about developing epidemics or developing viral threats. Is that right?
ProMed.
ProMed, sorry, ProMed.
Yes.
And could you just tell us a little bit about what that is and the extent to which that was used by you and others to be able to access information about the emerging virus?
It's been around a while. I don't know quite what you call it, maybe something a bit like a blog, but it predates even blogs. So it's a loose association of experts in the field who report to one another concerning events to deal with infections, right. Of which in a given year there will be dozens, if not hundreds, around the world. And that, I'm inferring that Devi used this as one of the sources of information. I actually didn't use that one.
Right, okay. And we've also heard some evidence from a number of the witnesses who have helpfully provided our Rule 9 responses of, not necessarily at this period, but in the period after this, as information started to emerge more about the use of preprints in analysing the emergence of the threat. Could you tell us what that is and the extent to which that was used in trying to understand what the threat was and the characteristics of the virus, etc.?
Yes, the gold standard for communicating scientific knowledge, of course, is the publication of a piece of research in a scientific journal, which is done subject to peer review. So it's looked at by experts, it's judged to be sound, and it's published. And that remains the gold standard. But in a very fast-moving situation like this, that whole process, well, quite frankly, it can take up to a year sometimes, and for some circumstances longer. So it's clearly far too slow. So preprints is the practice of taking the paper that you've submitted or you're planning to submit, but publishing it immediately. And it's made very clear on the preprint servers that this is not peer-reviewed research. So for that reason, it hasn't been quality controlled, but it's put out there so that the rest of the scientific community can see it. So it's basically a very fast way of communicating your research outputs, but it loses the quality control element of peer review.
Thank you. The reason I've asked you those questions, Professor, is that a number of other people, including the PHS representatives, suggested that the way in which evidence emerged over these early months, if we put it that broadly, from January onwards, about the nature of the virus and hence the nature of the threat, was unreliable or contradictory or difficult to interpret. It doesn't seem to be the case, even at this very early stage, and in fact you've referred to you developing views about this even earlier than this correspondence, that you, although no doubt are taking that into consideration, the reliability of the evidence, that is restricting you from reaching the conclusion that this is a very, very significant problem about to happen. Could you tell us about why it is that you felt confident enough in your professional assessment to be able to express these views despite those concerns expressed by others?
Well, one very simple way to do it is if somebody from, whether it's a scientist from China or the UK or anything, is publishing, wants to publish a paper, something they put up as a preprint. Beyond the preprint, someone would have to peer review it. That person would quite likely be me.
Right.
So I felt perfectly qualified to peer review the evidence I was seeing myself.
Yes. So you were able to evaluate what was in the peer review and use your extensive experience to be able to reach a judgment about whether this was reliable and sufficiently reliable information to be able to communicate these sorts of messages to government.
Yes, and during the pandemic, I didn't have time to do this for the scientific journals, but it's a job I routinely do for scientific journals. So I was simply doing it in real time in a different context.
Thank you very much. In this message, you go back again, as we said, this was the next day, and then you set out a number of different scenarios. Could we just scroll down a little bit further than that? There was one aspect of this where, just a little bit further than that, thanks, it's where you get to the measures we could consider are. You talk there about a vaccine being a part of the solution I think. And what at that stage would you have been thinking? Obviously, a vaccine would have been a very useful thing to have, but in terms of planning, what would your realistic expectations have been about when a vaccine might become available based on your extensive previous experience?
At that time, I think the fastest a vaccine had ever been rolled out from scratch was 4 years previously. Obviously, there was going to be a great need to accelerate the process. I really got that estimate of a year through correspondence that you already mentioned, particularly with Jeremy Farrar, who's director of Wellcome Trust and is very, very well connected with the vaccine manufacturing base. So I agreed with Jeremy, but I think his estimate was much more authoritative than mine, and that was.
So you just scroll down a little bit further. You mentioned antivirals there. Again, you say effectively that's something, for the time being at least, we're going to have to live without. So I think you're then pointing towards the need for what I think are non-pharmaceutical interventions in order to try and deal with the situation. And you mentioned there a number of different things with which we subsequently became familiar: case isolation, infection control, and contact tracing, social distancing. But also the thing I wanted to focus in on particularly was public messaging. What was it that you thought, you rather there suggest you hoped that the government was already doing something about that, but what sorts of public messages do you think should have been emanated, been sent out from that time onwards in order to try to manage the balance required between not causing widespread panic, but allowing citizens to be part of a bond of confidence with government about how their own health and safety is being managed?
You summed it up perfectly. That's exactly what I was worried about.
Right. So you think that there required to be some level of public messaging that reflected the need to balance those two considerations?
Yes, and I was doing, as part of my role at the university, a good deal of media work, even at that stage, and I was having to walk this tightrope myself. And it would have been very helpful if the Scottish Government had actually made some pronouncements that could then be discussed by the media and commentators and so on. So I was tiptoeing around exactly the problem that you identified.
I see. But is it correct to say, because this is one of the things identified here, that a level of engagement of the public appropriately pitched was necessary?
Yes, but I wanted it to come from government. Obviously one thing I could have said in media interviews at that stage was what's in these emails.
Yes. Yeah.
For rather obvious reasons, I did not want to do that. That should not come from me.
Absolutely.
But it wasn't coming from anyone else. Well, that was the problem.
You were, I assume, speaking to the very person in these emails from whom you thought it should be coming, yes. The Chief Medical Officer and the ministers whom she advised.
Yes.
There was then an exchange of emails, further emails, where you provided more information. Just for the sake of the record, the 31st of January email is INQ 000103352. And then in a further email, which we've seen, which is INQ 000103215, we've seen an email which was sent, not involving you, but it was sent by Dame Sally Davis, who I understand was the former Chief Medical Officer to the UK government, to Dr. Calderwood on the 5th of February, in which Dame Sally Davis oddly introduces you to Dr. Calderwood. Was that email the result of some contact you had with Dame Sally Davis about the position?
Yes. So we've discussed my frustration with what I continue to perceive as the lack of action. So I'm surprised you don't have the email, but maybe you have it somewhere else. I wrote to Sally, who I knew. And the email's there somewhere, but I'm paraphrasing slightly. I'm saying, Sally, can you get Catherine to listen to me? Because she's not listening.
Okay, thank you. And I think, again, if we have a series of emails here, again, all joined together under this reference. If we scroll up, there's a reply on the 6th of February to that message. You're copied into these messages, I should say, in which indicating that you had emails in the very recent past with some extremely helpful modelling estimates, she says to you, as you're CC'd in, let's find a time to meet face-to-face. You eventually did have a meeting with her, I think, but on the 28th of February, is that right?
Yes, that's correct.
Again, did that timescale between your original contact, the need to try to engage the assistance of Dame Sally, and the date of the eventual meeting, give you the impression that Dr. Calderwood was taking on board the level of the threat that you were trying to communicate?
I was less concerned about the actual meeting at that stage. What I hoped that Sally Davies's intervention had done would be suggest to the CMO that it might be perhaps wise to revisit my advice and what I've been telling her and take action accordingly. So I didn't push for that second meeting. I left that to the CMO's Scotland.
I see. Could I just run through some of the things that I understood happened roughly between the time of this email and the eventual meeting on the 28th? Just there, in order to try and get some key indicators of the developing knowledge of things that seem to us to be significant in the elevation of the threat. A meeting of SAGE took place on the 4th of February, in which it stated, on the basis of their analysis, that asymptomatic transmission cannot be ruled out and transmission from mildly symptomatic individuals is likely. It also indicated that human-to-human transmission outside China had occurred. Now, obviously, you've given us a lot of information across the various modules about the significance of asymptomatic or mild transmission. You had, in fact, predicted that it was at least a possibility sometime before that this would be the type of virus which could be transmitted by mild patients, and you've explained to us the significance of that. As at that SAGE meeting of the 4th of February, what was your view about the reliability of the evidence base that the virus was going to be transmitted by either asymptomatic, pre-symptomatic, or mildly symptomatic patients?
Thank you for mentioning pre-symptomatic, because it's very, very important on this. But the data on this was emerging in a very piecemeal way from China at the time. And me and many other epidemiologists around the world were trying to make sense of this data. I had a slight inbuilt advantage in my research group at the time. I had two very able Chinese students who were very useful in giving me intelligence and guidance as to what was going on in China and how we should interpret the sorts of information that was emerging. But China, and I believe the WHO, were at the time actively suggesting there was not much undetected cases, mild cases, that this was not the pattern. It was completely wrong, but that's what they were suggesting at the time. So this created a lot of doubt.
It might be difficult to know how many undetected cases there were because the mild asymptomatic or pre-symptomatic spread means it's hard to detect them.
Yeah, but they did surveys, but they didn't interpret the results the way I interpreted the results.
Yes. So at what point over this period, did the evidence base, which, as you say, was not entirely satisfactory, although you had the advantage of two able Chinese students assisting you, at what point over this period did it become apparent to you, based on the kind of judgment that you have explained you apply to evidence and papers, that asymptomatic, pre-symptomatic, or mild transmission was going to be a likely feature of this particular epidemic?
I don't think the evidence for that became firm, the sort of evidence you would publish in a scientific journal for quite some time. I don't think that happened in February.
But it was definitely part of the thinking.
Oh, yes. Oh, no, it was absolutely part of the thinking. We were concerned, but again, the evidence hadn't emerged. There were systems set up, which Scotland was involved in, an exercise called the First Few Hundred. I think you've heard of that.
Yes.
And that was designed to provide, among other things, this sort of information. But of course, in order to activate something called the First Few Hundred cases, you have to have 100 cases here in the UK or in Scotland or wherever. And we were nowhere near that number.
Yes,
stage.
of course. Yeah. Well, as far as testing is concerned, that was something else I was going to ask you about. The earliest record that we have of tests being conducted in Scotland is, I think, around the 10th of February. When was it that a test in its most basic form, if you like, was available?
Wouldn't have been long before that. I don't think that's. I don't think there's any. I don't have any concerns about that.
Yes.
I think that first test date was pretty good.
Yes. We know that because there were 57 tests conducted that day. All were negative, so we're not contributing to positive tests. Yes,
but the principle is established, and I'm glad it was. That was a welcome development.
Absolutely. Thank you. You met Dr. Calderwood on the 28th of February. We have a briefing note, which is INQ 000103216. This is a note, I think, that you sent her in advance of the meeting. Further down towards the end, you sent her a lengthy analysis of the position as at that date, as things have developed since your initial correspondence. And then a bit further down, thanks. Yeah, you say there are two scenarios we particularly want to avoid: doing nothing, as that is likely to result in the health system being overwhelmed in a matter of weeks once an epidemic takes off; implementing extreme social distancing measures that, sooner or later, have to be relaxed; and then, having already paid a high social and economic cost, experiencing a delayed epidemic that still overwhelms the health system. So there's a degree of balancing, I think, required there as well. What was it you were trying to urge in advance of your meeting in this lengthy, detailed briefing note what were you trying to urge upon Dr. Calderwood as important things to bear in mind in this overall scenario assessment?
Yeah, exactly what I say there. I mean, it was clear to me at that stage that we were going to have to walk a tightrope between an epidemic that took off, basically, and overwhelmed the health service, or wasn't thinking of lockdown in those stages, but at that date, but some very severe social distancing restrictions that would be extremely damaging in their own right. We were walking between two very, very unsatisfactory outcomes. So this was going to be difficult.
Yes. What was your view at this point, towards the end of February, about what Scotland could have done in order to try to handle the threat as it was at that point?
Well, we started to discuss this in the meeting. I think it's the next day after this. So it's I don't know if I say it in using that phrase in that meeting, but one of the things we've been working on there was this idea that earlier intervention can be less drastic intervention. So if you want to avoid these very severe social distancing measures, then actually you're going to have to intervene earlier. But I'm not sure I was quite at that stage in my thinking at this meeting. I think that maybe emerged. First time I did a briefing on that, I remember that one was March 4th.
Right.
So I may have mentioned it to Catherine
yes.
at that meeting. It was certainly in my mind,
yes.
but I don't think we'd actually written it up, that earlier intervention can be less drastic intervention.
There's some other email correspondence that we've seen. We could take that one down there. Thank you very much. Some other correspondence relating to the meeting, slightly after the meeting, in which one of the things that you refer to is social distancing measures were very likely to need to be introduced in Scotland, possibly very soon. In your statement, you say that meant days, not weeks. And you also point out that there would be a need for a clear exit strategy. And also some level of analysis of the effect of social distancing economically, socially and psychologically. So you're setting this out presumably at or immediately after the meeting. Yeah. Could we just look at those different components? At that stage, as far as the measures that were concerned, what did you think needed to be done? The second was the exit strategy, and the third was some level of analysis of the effect of social distancing measures emotionally, economically, socially and psychologically. If you could explain the significance of those and your position at the time.
Yeah, so it is, as you said, I'm setting out the need to balance harms. And this is absolutely fundamental to public health. In public health, you're always balancing harms, even if the harms are just monetary costs. But it's always a balance you're trying to strike. My concern here, and this comes back to the scale of the crisis that didn't seem to be landing in government at that stage, is both harms, the harms that the virus could cause and the harms that the countermeasures could cause, were immense. Mm-hmm. They were absolutely enormous. So when I'd been doing this sort of exercise over the years of trying to make an intervention, a health intervention, efficient, so not too costly, not damaging other ways, the stakes were nowhere near as high. Mm-hmm. There's a little bit of wiggle room. I mean, you get it wrong this way a bit or that way a bit, and it costs the government a small amount of extra money. But here, the stakes are absolutely enormous, and we have to find the right path. Mm-hmm. If we go too hard or too soft, we're going to end up paying an enormous penalty, and this was very obvious to me. Well, as you saw from during late February, that we were in this position. Mm-hmm. So I'm trying to lay the ground for this sort of decision making that's going to have to happen. Yes, if we're not sort of damage. And
I think you tell us, or these documents show that you are not aware of any. You're talking about the other side of the balance, if you like. We've heard something which we'll come on to later, which the Scottish Government introduced after this in April, that we call the 4 harms strategy. The first harm being the harm of COVID itself, the other harms being harms caused by the measures taken to combat COVID, the non-COVID health harms, the societal harms and the economic harms. Is it your understanding that at this stage within Scottish Government no analysis had been done of the effect of even the social distancing measures short of lockdown, which you are suggesting might be contemplated?
None at all, as far as I'm aware.
Okay. The other element of what we discussed there was the exit strategy. Why was it important to have an exit strategy?
Simply because the sorts of interventions, the social distancing that were being contemplated at that stage were clear, and that include things like school closures that were on the table, were clearly very, very harmful. And equally clear, they could not be implemented indefinitely. We couldn't, well, it turned out to be a lockdown in the end. We couldn't lock down indefinitely. So the lockdown had to come to an end. So what would be the strategy, the exit strategy? What would make you decide that you could exit lockdown? And the reason that's important is because the exit strategy is going to also determine how long the lockdown is. So what are we preparing for? So you could imagine that came up later, the sort of circuit breaker type approach where actually the lockdown is just a week or something, or all the way up to an indefinite lockdown until we got a vaccine. So there's a range of possibilities. So and it's very difficult to advise on what the best strategy is unless you know what the government is willing to contemplate. I mean, can I give you a very simple example?
Absolutely, very helpful.
If the government was willing to contemplate an indefinite lockdown, and forget all the costs and the harms that would do, but that they were willing to do that, then my advice would be, right, do it now. Lockdown now. That's the way to minimise the impact. But obviously they can't do that. We'd be locked down for possibly years if we'd done that. It's completely impossible. So as soon as you accept that the lockdown has to come to an end, then the question arises, well, then when is the best time to do it? And suddenly you're in a different space. The decision is no longer nearly so easy. And the reason this is causing us all such concern at that time, and there was a lot of work going on about the best timing and duration of what turned out to be a lockdown, should be, so the severity of the intervention as well, is because it hadn't been done before. Because we'd never contemplated lockdown as a public health policy at all. This was completely new. We ourselves, I mean, you kindly call me an expert in the field, but I've never thought about this before. Never contemplated it. So I got my team frantically working, how is this going to work? What's it going to what's it going to look like? How long should it be? When should it be implemented? What's the exit strategy? We're working very, very hard to try and understand something that, if we'd known it was going to be on the table, we would have spent years researching before, so that we understood all the nuances and all the trade-offs and how actually you should do it. But none of that work had been done because no one around the world had ever contemplated lockdown. So we were frantically trying to catch up.
Which explains why I think that your correspondence at this time isn't referring to lockdown or anything like it. It's referring to social distancing measures, or even more extreme social distancing measures, because lockdown simply was not part of the narrative and had never been prepared for.
No, so of course it was on the radar because at that stage the city of Wuhan had been locked down.
Yes.
Obviously we were very aware of that and that had been widely discussed. But I think the realisation that something like a lockdown would have to be contemplated for Scotland took rather longer.
Right.
And,
did you have the impression over this period and up to the point at which the lockdown actually occurred that there was any clear exit strategy in the mind of the Scottish Government?
In the end, when we went into lockdown, I don't think they had the faintest idea how long we would be in it for.
And as regards the matters we discussed, the systematic analysis of the effect of the lockdown or social distancing measures economically, socially or psychologically, did you have any impression that any such assessment had been done within Scottish Government?
Absolutely none.
You met with Dr. Calderwood again on the 6th of March, and there is another email follow-up in the same way as you'd done on the previous one, summarising your position. There's one element of this advice at this stage that I'd like to just draw your attention to specifically to ask you some questions about. You see there are 3 social distancing measures informed by the modelling work of Imperial College and communicated through SPIM. It's the third one I was interested in asking you about, if you could explain. One of the things that you're suggesting is that there should be a policy of cocooning populations about the age threshold that you've mentioned. What is cocooning, and why was it part of the strategy that you were proposing might be contemplated by the Scottish Government at this time?
So our understanding has developed considerably by this stage. You pointed to my January 21st email where I identified that there would be likely to be a subpopulation of very vulnerable people. We now had very good data that there was tremendous variation in the risk with age. So the idea then is, well, how do you protect people who are very vulnerable? This seems to me, I have to say, to be actually the absolute #1 public health priority for Scotland and everyone else. We've identified a subset of the population that's at very considerable risk. We spoke about the case fatality rate, and we said that the case fatality rate of 4% was high. But in the elderly and the frail, it's way higher than that. So these people are very, very vulnerable. So how do we protect them? And I hadn't thought of this concept of shielding as it eventually was introduced, which is basically asking a lot of people in the community to protect themselves. So we had this idea of actually protecting people by protecting the people around them. So carers, family members, same household, that we had to pay particular attention to this. So that's what I was proposing, and that's an idea that we went on to develop. So
cocooning then is protecting not only those vulnerable people, but the people who would be likely to engage with those vulnerable people, their carers and so on. Is that right?
Yes, likely, but not through choice, but through necessity. Because elderly people, but particularly, of course, elderly people with other risk factors, other comorbidities, need care, whether it's in the home or it's in a care home, or even some in hospital. This is a subset of the population that really couldn't socially distance. It's just not possible. They can't.
Yes.
So clearly that wasn't going to be, unfortunately, was the strategy that was implemented, but just telling people to isolate themselves. But it seemed to me that we needed to actually We couldn't isolate themselves, so that wasn't going to work. So how do we do it? And we do it by cocooning.
Yes, I see. Was cocooning a policy which ever formed part of the Scottish Government's response to the pandemic?
No, and that wouldn't have mattered had somebody, there's a lot of very smart people thinking about this problem, come up with a better way of protecting the vulnerable population. But what we got was shielding in the form that it was introduced in Scotland, which in the community anyway was basically telling people to cut all contacts out, which there's lots of evidence now that didn't work particularly well, and I can give you chapter on verse as to why it didn't work if you want. But yeah, that didn't seem to me, even at this stage, to be a very good approach.
Thank you. There's a comment there as well, just on this particular suggestion that Gregor, who I'm assuming is the now Chief Medical Officer, raised the point that there might be vulnerable people below the chosen age threshold as well. Personally, you write, I don't see any reason why risk factors other than age couldn't be included in a cocooning policy, but as for the clinicians to advise what those might be. So you've obviously identified age as the main risk factor on the evidence that you've seen, which of course turned out to be absolutely right. But there's a suggestion made by the then Deputy Chief Medical Officer that we might need to consider other groups vulnerable to the virus as well, and you are open-minded about the possibility of doing that because you recognise that there might be such groups who could be protected by similar mechanisms.
Correct.
Thank you. Could we just go down, have the whole email up as well, please? Over the page, I think. Yes, do you conclude this email by saying one final point, perhaps the most important of all? A lot of work went into making containment work, quite rightly, but it hasn't, as was to be expected. A lot of work is now going into making delay work, quite rightly. It may work or partially work, but there remains every likelihood that it won't work well enough to prevent an epidemic that does sooner or later completely overwhelm our health systems. This is not a prediction, but it is an entirely possible scenario. If it happens, it could happen within weeks, so I do think that we should start thinking about the mitigation phase now. Can you summarise for us what you were trying to convey as to the strategy at this stage, what needed to be borne in mind as strategies started to be put in place in the weeks after this?
Yes, so the UK government had this strategy, containment, delay. There was a research arm, which is a little bit of a diversion. So containment, delay and mitigation. And this was, Chris Whitty, I think, was...
Yes, I think it was part of the UK Coronavirus Action Plan that was launched on the 3rd of March, to which the Scottish Government also subscribed.
Thank you. You're right. So I'm now trying to tailor my comments to fit in with the actual plan. I mean, there is now a plan, so that's progress. But I'm trying to tailor my comments to fit in with that plan. But I don't think that plan is going to work.
Yes. And what is it that you are counselling particularly about the dangers that plan might not work?
Well, I mean, what I'm saying is quite clearly that we should start thinking about mitigation, which is basically, okay, how do we deal with the fact that we're actually going to have an epidemic? We haven't contained it. We've delayed it as long as we can, and here we are. We have a pandemic. What are we going to do?
Did you understand over this period, did you take the Chief Medical Officer and other medical advisors to the Scottish Government with whom you were speaking to be receptive to your advice in the period from January up till the first lockdown, or not?
Well, we've discussed the difficulties I had getting myself heard up until February, so I think the only answer I can give you is no, I wasn't. I feel it did change, the tone did change in March, and that coincides with Gregor Smith getting more actively involved in the discussions I'm having with Catherine Calderwood. And I think the pace did pick up, certainly in the first week in March.
Was Gregor Smith then considerably involved in the planning as far as you're concerned around that time? It wasn't simply Dr. Calderwood?
I don't know. I'm simply referring to his involvement in the correspondence with me.
Yes.
And he was starting to ask questions that were the sort of questions I would
Yes,
wanted to be asked.
we've heard evidence from him, for example, that he attended a number of the early SAGE meetings as an observer where he was gathering information, and he was obviously then part of the discussions with you.
Yes, but I mean, we've discussed before here that I don't think, and many other people think, that those early SAGE meetings were particularly doing a good job of raising the alarm.
Thank you. After this, you, of course, were attending SPIMO, and you communicated, I think, some messages with information about what had happened at those meetings in early March to Dr. Calderwood and Dr. Smith. Is that right?
I did. So this became a modus operandi for us, that I would brief the pair of them on the outputs of SPIMO. And I think that was important. There were, as you well know, there were many sources of information coming in. But in terms of the sorts of questions that needed to be tackled then, SPIMO was absolutely the repository of expertise and knowledge. And so I think it was, I felt it was important that they were fully appraised of what SPIMO's thinking was.
Okay. We've discussed the absence of certain features of the Scottish Government strategy before the first lockdown, but in that regard, what was your understanding at this time within the Scottish Government of their planning with regard to the way in which Scotland might deal with a second wave of the virus were it to eventuate?
I gave in my briefings that we've been discussing to Catherine Calderwood, so this is, well, I think actually some of it is even before we had cases in Scotland, but we have some idea of the sorts of social distancing intervention we might need. I said then that we were going to get, well, not that we're going to get, as you well know, I don't do that, but we were very likely to get, should plan for, the possibility of a second wave. And do you want me to give the reasons for that?
Yes, please, yes.
Right. The reasons for that is I was acutely aware that lockdown, or any combination of social distancing measures up to and including lockdown, would not solve the problem. All they would do was delay the problem. And the first manifestation of that delay is, okay, you get another wave. Mm-hmm. And then you push that, and I shared this scenario with them. You push that one down, the second wave, which, as it happens, in the briefings I gave, was September 2020, the second wave, so pretty close. And you quash that one down, and then you get another one in the early part of the next year. Now, you know, there's no way you can predict with any precision how something like this is going to unfold over such a long timetable. So we wrote in very big letters on our graphs and briefings on this, this is an illustration, not a prediction. This is the sorts of scenario that are coming up when we do our work, and we're sufficiently confident in something like this happening that the government should be aware of it and should be planning for it. I don't think they had any understanding, not just in Scotland but in the UK, that they were going to get a second wave. That was the likelihood. You know, they should be planning the expectation they're going to get a second wave. I think there was a general belief that we would lock down, perhaps for a few weeks, and somehow the thing would be over. Extraordinarily naive view, but it clearly was circulating in the political circles around the UK. This was a temporary measure.
And indeed, contrary, as you said, to the advice you were providing about your experience of how these things tend to go in the briefings you were giving directly to the Scottish Government.
Yeah, more than how they tend to go, and based on the best analysis we could possibly do of the data on this particular infection in the UK, in Scotland. So no, not just based on expert guesswork. A lot more to it than that.
At a general level as well, another thing, you say this both in your book and also in the evidence you've helpfully provided to the module, that you had the impression that the Scottish Government's policy with regard to the management of the pandemic was that no death from coronavirus was acceptable. I'd be interested in knowing how you got the impression that that was the policy, if you like, or the approach, and also why it was you think that that policy caused significant problems.
So I thought it because the phrase appears in the Scottish Government's I've got it here, Framework for Decision Making, published in
the April document that I referred to
2020. And because, as I recall, the then First Minister said it several occasions. That's why I thought this was...
Thank you. And the second part was why, if it is the case that you consider it to be a problematic approach, it was a problematic approach.
It's empty rhetoric. It misleads everybody. Misleads the public. It gives an entirely false impression of what the future holds, how this pandemic's going to look. The idea implied by no COVID death is acceptable is a world where no one dies of COVID. That had gone. That had gone from December 2019. That was, as it turned out. But certainly I was clear it had gone by February 2020. And that's true because this year, 2024, current rates and similar to last year, hundreds of people in Scotland are going to die of COVID. Is that acceptable? Well, we seem to be accepting it. I mean, there's no great public health effort going on here to spare those hundreds of lives that are going to die of COVID. And as an aside, I think we're now not paying enough attention to COVID. Now it's a serious infection. It's killing people. May I go on?
Yes, please.
The second issue is, okay, how are you going to achieve this no deaths is acceptable? Well, the only possible way I could see of achieving it, other than literally some miracle cure, but let's leave that aside, is a zero COVID policy. And as I've explained to you before, the corollary of a zero COVID policy at that stage, this is April 2020 we're talking about, is indefinite lockdown. And it would still fail eventually. And this was being discussed at the time, and of course zero COVID did fail globally eventually, and so therefore it was never deliverable. And the other thing that upset me about this no death from COVID is acceptable, it devalues non-COVID deaths. And that isn't just a sort of philosophical complaint. The intense, very strong advice in Scotland to spare the NHS, particularly during the first wave, and not bother the NHS if you didn't absolutely need to, led to a huge spike. Well, first of all, it led, as you expect, to a fall off in the cliff, and the EVE project, of which I was a part, studied this on attendance at A&E or admissions to hospital. They just fell off a cliff. Most of the hospitals in Scotland had their quietest time in living memory during the first wave because no one else was going to hospital. And a lot of those people should have been in hospital. And in UK, thousands of them died at home. There was a massive spike in this. In Scotland, I think it was probably hundreds. I wouldn't want to put an exact figure on it. These people died. And so they died because the focus of the government was on preparing the NHS Scotland for COVID and concentrating on that. Because no COVID death is acceptable. Other kind of deaths apparently are. And they rose.
Thank you, Professor. To put that in the language of the Scottish Government framework, there was a significant focus on harm 1, COVID-related harm and death, but too little concentration on harm 2, non-COVID-related harm and death.
Absolutely, and that killed people.
And one, it would be reasonable to assume, would it not, you mentioned the non-COVID deaths, but of course there may be many people who have suffered significant morbidity as a result of not attending the hospital, whether that resulted in their death or not.
Well, indeed, but I mean, the non-fatal health harms went beyond that, and we might come to this. There was a study looking at the sort of health effects of both COVID, but also the implications of lockdown, so the indirect effects of the countermeasures, and that showed, by their best estimation, this was done by the Office for National Statistics and the Department of Health and Social Care across the UK, that actually those indirect harms not so much during 2020, but accumulating over time, would be considerably greater than the harms that would be caused by COVID. Sorry, having gone down this route, I must add an important rider.
Yes.
That is not a reason not to intervene against COVID. If you don't, then that side of the scale increases enormously. So, but it is an indication that we haven't got the balance right. So it's confirmation. It's another way of looking at the problem that you just highlighted as in terms of neglecting harm two. This is another piece of evidence that said, yes, we've neglected harm two, but not just in the short term, in the longer term as well.
Thank you. If that's an appropriate moment, lady.
Professor, as you know, we take regular breaks for the stenographer. I shall return at 11:30. Mr. Dawson.
Thank you, lady. Professor, we were discussing before the break your impression of some of the key Scottish Government policies towards the management of the pandemic and their effect. I just wanted to ask you about one particular thing you say in your statement, which is related to the first lockdown, which is at paragraph 240, where you say, I do not know what Scottish Government's understanding of the COVID threat was at the time Scotland went into lockdown, but I don't believe that they truly accepted that the virus was here to stay. I am concerned that this short-term view of the crisis influenced both the politicians' willingness to impose lockdown and the public's willingness to accept it. The politicians were mistaken or misinformed, and the public were misled. You've given some evidence about your general impression already. Is there any element of that you feel you would like to, anything you'd like to add based on that comment in light of what you've already told us in this regard?
Well, I can argue that what I say in that paragraph was correct. And the reason I say that is because by the end of the summer 2020, Scotland was flirting with a zero COVID strategy. Well, that tells me they didn't accept that the virus was here to stay.
And you think that was an important error in the way that they approached really the entire management of the pandemic, but certainly over 2020? Sorry, what's the error precisely? Well, the approach that they had, their approach to the COVID threat was that they did not accept that the virus was here to stay. So I have to say I didn't understand the Scottish Government strategy over the summer of 2020. The emphasis was on a very, very cautious relaxation from lockdown. And it seemed to be important to the politicians that it was more cautious than the one in England. So they were emphasising that. They didn't articulate, in any way that I understood, what they thought the public health benefit of this caution actually would be, and given what we've said about a second wave. And then this segued into this idea that actually the fall in cases in Scotland would somehow continue and we could end up in zero COVID. So that, to me, was... I'm trying to think of a polite way of putting this. This was not consistent with the evidence that had been available since February 2020. So there's two elements, I think, to that period. One is whether it was the best way to approach things to release the lockdown in the gradual fashion that the Scottish Government did. And secondly, whether the zero COVID policy that you understood to have existed within Scottish Government showed a misconception about whether that could be achieved and sustained. So if we could try and take the two, one after the other. So, just to put the first in context, you give an analogy at paragraph 16 to 17 of your report, which I think attempts to try to explain your views on this. I just want to try and unpack it a little, to do with a seesaw. Whereby you talk about there being a difference between how far you go in relaxing restrictions and how quickly you get to that point. Could you please explain your views about that in the context of the Scottish Government's policy over that period which you've described?
Yes. As I say, I don't think the goals of the policy were clearly articulated. Not so much the immediate goals. They were laid out, and in May 2020 there was what was called a route map. So that was clear. That was absolutely clear. But my concern, and had been for so many months, was, but what is the long-term plan? Mm-hmm. Where do you see this going? Where are we going to end up? And as you well know, I was expecting to end up pretty much where we are now in 2024. But they didn't seem to be thinking that way. So the seesaw analogy is this. The emphasis on caution was somehow the idea that you could unlock, well, I think I'll come back to this, all the way. You could come out of the pandemic by going very, very slowly. And the seesaw analogy is you're standing, just you, on the one end of a seesaw. There's a fulcrum in the middle of the seesaw, a tipping point, and the tipping point is actually the value r greater than 1. And the argument is that I think the Scottish Government were making is if you go slowly enough along the seesaw, you can go past the fulcrum and keep going. No, you can't. It's going to tip down. And I don't think they understood that. And I didn't use the seesaw analogy at the time because I wasn't absolutely sure that's Scottish Government thinking. But it became very clear to me it was when we got into the second Scottish lockdown in January 2021. And repeatedly we heard that we're going to come out of this lockdown very, very slowly and cautiously because we made that mistake before. Well, no, that's not correct. So what you have to avoid, what the strategy should have been, was this: you can go as far as you can up the seesaw as quickly as you like. It makes no difference at all if you take 2 great steps and get there, as long as you don't go across it. If you want to go across it, then you have to do something else. You have to basically reduce the R number in other ways. So what I wanted to see was 2 things. So one was immediate, much quicker than the Scottish Government did it, relaxation of restrictions that were not clearly going to take us to the tipping point. And you want examples?
For example, please, yes.
Oh, well, I can give you 3.
Yes.
So, and there's very, very good evidence for all 3 now. The stay-at-home orders, the fact we were asked to stay in our homes, that was not contributing much. And well, this is getting complicated now. Okay. We can perhaps go back to a graph in the Scottish Government's framework, the COVID document, that shows this. But what that graph shows is essentially the R number coming down before we were told to stay at home. And when we were told to stay at home, it didn't actually come down any further. And it's worse than that in Scotland. There are more ramifications.
So just to pause at that point, what you're telling me is that your scientific view was that the policy of gradually easing the lockdown didn't make a great deal of sense to you, didn't have scientific rationale.
No.
In particular, just take it stage by stage, in particular because your view was that you could get to the tipping point, i.e. release restrictions to a point where there was a degree of stability in the situation. And if you moved quickly towards that point rather than gradually, you would offset some of the ill effects of the countermeasures more quickly than a gradual release. Is that broadly correct?
Correct. I mean, the effect of the stay-at-home measures really, they weren't, I don't think, released until May or June. I mean, it was ages before.
And what I think you've identified is that there were a number of particular measures that you think could have been released more quickly.
2 more.
Yes, we'll get on to the others, but just to take it stage by stage, Professor. There are 3 particular types of restrictions that we all lived with that you think, based on that previous general rationale, should have been released more quickly, which would not have had a significant effect on the R number and would have significantly released some of the other harms related to those restrictions being in place.
yes, not had no effect on the R number, but given our understanding at that stage, we could be very confident they wouldn't take us past the tipping point.
Yes. The tipping point being?
R becomes greater than 1.
Yes, thank you.
So one was stay-at-homes. The second one was...
So could we just deal with the first one quickly, just to be sure that we've understood this, because, Professor, it's extremely interesting and important evidence, and a number of people will be listening to this who perhaps need to be taken through it a little bit more slowly, just so we absolutely understand everything you say. The first thing that you suggest could and should have been released more quickly, from a scientific perspective in your analysis, was that the stay-at-home order could and should have been released earlier. And you say that there is scientific evidence to say that that would not have tipped the R above 1.
Yes, I mean, I would take that further. The stay-at-home order was never necessary.
Right.
The job was already done by the measures. And I say there's actually evidence in the Scottish Government's own report that was the case.
So that is based on evidence which shows that the R was starting to decline even before the lockdown.
Yes.
Did that result from the fact that people were voluntarily imposing on themselves a degree of social distancing such that the R was starting to be brought under control without the need for that severe imposition of a lockdown?
That's my inference, and I think a good inference. There may be other explanations, but that's the one I would
Thank you.
highlight.
And you were going to tell us what the other 2 significant restrictions were that you think could and should have been released more quickly.
Outdoor activities. We had very good evidence going back from China that the novel coronavirus transmits very poorly outdoors, very poorly. So there was pretty much zero public health benefit to keeping us indoors. That wasn't required at all. We never needed to do that. There are caveats, like if people are outdoors and being intimate. Well, yes, okay, that's something, but
outdoors per se.
Yes, there was never any need for that, and the evidence.
Could I just dwell on that before we get to the third one again?
Yes, sorry.
Just to understand, the restriction to stay indoors was something then that you say should have been released faster and earlier, and in fact shouldn't even have been there at all. Is that right? Would it be fair to say that had there not been restriction on going out of doors, that would have perhaps contributed to counterbalancing some of the other harms, such as the mental health harms or the physical harms that people might have started to suffer from being inside so much?
Absolutely, but I heard or saw very, very little consideration for those harms when we went into lockdown. To be fair, they were, I think, fairly quickly recognised by Scottish Government, but when we took that decision, I don't think that was at the forefront of people's minds. There was a lot of concern about how well people would tolerate lockdown, but that was an unknown. Mm-hmm. But I felt that discussion was more in the vein of, well, how long and severe a lockdown could we get away with that the public would tolerate, rather than actually looking at evidence of components of it and saying we didn't need them.
Okay.
Professor Woolhouse, sorry to interrupt. When you talk about outdoor activities, are you meaning things like going for a walk in the park, or are you talking also about outdoor activities like football matches?
Football matches were on the cusp.
Well, because a lot of people are gathering, they're going there by public transport, they might go to a pub together, all those different variables.
Yes. That would, I mean, you'd need to do a fairly detailed public health appraisal of where you drew the line. But we, in the UK, arrested people for going on solo walks in the mountains. That's just utterly absurd. That devalues the whole idea of social distancing when anyone can see. This is nonsense. But it was done. May I?
Absolutely.
Another good example, there was an absolute outcry in the summer of 2020 that people were going to beaches. There was never, ever an outbreak of COVID-19 anywhere in the world linked to a beach. It was fine. People could go to the beach. But nonetheless, we were very resistant to that.
Thank you, Professor. The third element that you were going to tell us about that should have been released more quickly was?
So this is not in the category of things we knew well enough not to include them in the first lot.
Yes.
The first two, we never needed.
Should never have been there.
Yep. 30 schools. And it quickly became apparent through April and May 2020 that schools were contributing a little to the spread of the virus, but so little that there was essentially no danger that reopening schools would take us past the tipping point.
Just to pause there, I think, because you said it very quickly, I think you said there the closure of schools, is that correct?
Yeah.
It just wasn't quite picked up by the stenographer.
I beg your pardon.
So
Closing schools, I accept as essentially as a precautionary element of the first lockdown, because let's face it, we were practically panicking at that stage. It was necessary or justifiable. But we should have realised much, much more quickly, based on the evidence emerging from around the world, that this was not an essential element of our lockdown. So in my view, and when we come to this, I argued it repeatedly and frequently over that whole summer, schools in Scotland could have reopened in May 2020, just as they did in Denmark.
And what about school closures as part of the second lockdown, which also occurred?
One of the positive elements of the way the pandemic was managed in Scotland was that we were the first nation to reopen schools when, particularly in England, there was a lot of resistance to it. I think we did that partly, at least partly, on the basis of the advice that came out of the Scottish COVID Advisory Group, which I was a part. I think that advice was too slow to pivot to it's safe to reopen schools, but it did get there, and we opened them in August. And I thought that was a real success story, an evidence-based decision by Scotland to do something that was safe and was so important to do. And I was feeling that actually being an advisor was quite a good thing, that actually we could get things done that really helped. And then when we had the January lockdown, schools were closed again, arguably because this was now the alpha variant and there was more uncertainty, as a precautionary principle, yes, but it very quickly became apparent in that second wave that schools did not need to remain closed and we could still control the virus, and yet they weren't fully reopened here until May 2021. This was unnecessary. Forgive me, this is one of the aspects of the pandemic management that I really feel very strongly what we did to the children. And it would be bad enough if there was a detectable and measurable public health benefit to this, but there wasn't. It wasn't necessary, and we did it anyway.
Could I just clarify one? It could be applied in connection with the schools, the evidence you've given, but it could be applied more generally. When you differentiated between the first two categories, which you say should never have been in place, and schools which you accepted would have needed to have been in place, but for a much shorter period than the restrictions actually applied, that is based on the position in which Scotland found itself when the lockdown was announced on the 23rd of March. Is that correct?
It's based on the evidence that was available when that decision was taken.
But is it your position, if one takes it further back in our narrative that we've been discussing, to the discussions that we had about the warnings you were trying to convey to Scottish Government, if we were trying to assume a hypothesis which worked on the basis of those being heeded in the way that you had hoped they would be, would it have been possible to have avoided that happening in that scenario and indeed avoided a lockdown at all?
Yes. May I hark back to Module 2?
Yes, if it puts it in the context which is required for Scotland,
yes,
that would be very welcome. Thank you.
So, Module 2, Mr. O'Connor was interrogating me quite hard about the difference between my maxim for managing this pandemic of go early so you don't have to go hard. And he pointed out Patrick Valence's counter to this, that you should go harder than you want, earlier than you want, wider than you want. And Patrick Vallance, when he gave evidence after me, to Module 2, addressed this, and he said, well, yes, but how hard, you know, Professor Wyatt says you don't have to go so hard, but you still have to do something, so is that not pretty much the same thing? That was his argument. Well, my counter to that is no, it's not, for the reasons we just gave. So if we had gone earlier and done all the things, apart from the three I mentioned, and seen them working, we would never have had to close schools. We would have seen it wasn't necessary. So I don't accept Patrick Vance's counter to that at all. I mean, you know, his strategy led to us closing schools. Mine would have let them stay open for the whole pandemic.
Thank you. Can I address another general concept which flows through all the evidence, I think, that you've given, which we've touched upon? And again, to try to use it's developing a theme we've talked about earlier in the context of zero COVID policy. To use the language of the framework, the area that I'd like to explore with you is the extent to which what you perceived and understood the greater focus on harm 1 to be resulted in harms 2 to 4 being much worse than they really should have been. Broadly speaking, can you explain, Professor, your view as to whether the Scottish Government policies took adequate account of we've already covered non-COVID health harms, but wider societal and economic harms?
Very simply, in my view, no, they did not. But then we get into this very difficult territory, which the politicians exploited a lot. If you don't intervene as hard, more people will die. And since they were working on this maxim that no COVID death is acceptable, clearly that's not something they're going to do. So in order to counterbalance these relaxations, you have to do other things. And not only me, but Scottish Advisory Group was very clear on the other things you could be doing to keep the R number low, but still allow you to relax restrictions and therefore avoid a lot of the harms that were being caused, the harms 2, 3 and 4, as you say.
We have evidence available to us from Scottish Government that during the course of 2020, for differing periods at different times, a number of advisory bodies, separate from the body to which you were affiliated, the Scottish COVID Advisory Group, were set up in order to try to provide advice and evidence information to the Scottish Government about a wide variety of things, including things that might broadly be described as falling in harms 2 to 4. There are those, the remits of those groups are all set out. But if your position is that ultimately, in terms of effect, the Scottish Government's policies failed adequately to recognise those harms over the course of the pandemic, must it be the case that those systems were ineffective in that the ultimate impact from harms 2 to 4, so I understand your evidence, was larger than it should have been?
I think to a large extent the 4 harms policy, which when the 4 harms were first mentioned, I was greatly encouraged.
Yes.
I was thinking it was rhetoric. It was rhetoric. The emphasis was overwhelmingly on harm 1, even when, particularly during summer 2020, the public health benefits of continuing to suppress the virus were extremely small.
Thank you. I'd just like to focus in, we've talked about it already, the period when the cases started to rise again, which eventuated in the second lockdown. Is it your view, in relation to any of the harms, frankly, the harm that you're focused on, harm 1, or any of the other harms, that you think the Scottish Government learned lessons about the experience of the period up till, say, September 2020, as regards how best to manage the pandemic, or that they repeated the same mistakes?
I think, the second lockdown in Scotland, of course, was January.
Yes.
And cases rose in the autumn, as you said, in the second wave, but also came down without a full lockdown in Scotland.
Yes.
So that was a big difference from England. And
Just to be clear, there was not a full lockdown, what's known as in the other nations a circuit breaker lockdown, but there were significant restrictions at times imposed over that period. And
I think, sorry, I've completely diverged from your original question. Can I address this point and then come back?
Absolutely. Thank you very much.
Right. I think one of the reasons that we didn't in lockdown, in Scotland, go into that November lockdown was it would have been counter to the advice coming out of the group I was on, Covid-19 Advisory Group. We were not in favour of a lockdown at that stage. And as I say, we had proposed many other interventions that would reduce. But even though most of those weren't taken up, in fact, we didn't need the lockdown in Scotland.
Just to be clear, Professor, was it, you mentioned November, which is obviously when the English lockdown took place. There were other lockdowns. Over that whole period, really from September onwards, there was consideration of a circuit breaker. Did it remain the Scottish Government COVID Advisory Group's position that they didn't recommend a circuit breaker over that whole period?
Correct.
Thank you.
Yes. And again, harking back to Module 2, I'm afraid, I know the inquiry was given evidence from a number of very distinguished scientists and advisors about the inevitability that this second lockdown in England was absolutely essential for controlling the virus. Well, we didn't have one in Scotland, and we controlled the virus. So I have to say, I think that simple fact rather discredits all the evidence the inquiry's heard on this point before. Scotland proved what I have been claiming, that second lockdown in England was unnecessary. It wasn't necessary here, it wasn't necessary in England either.
As regards the second lockdown in Scotland?
Right, the second lockdown in Scotland was January. And yes, you asked me if Scottish Government had learnt some lessons. They learnt some. So the restrictions that were imposed on us during that lockdown were definitely less severe. The very strict stay-at-home orders, the amount of time you could spend outside, those were relaxed in that second lockdown, so that's fine. And again, proof of principle, even with a more infectious variant of the virus, we didn't need them. We still controlled it, so that proves what I was saying about the first one. We didn't need those elements. But sadly, they did close schools and kept them closed, so they didn't.
Which we've touched.
Yes, but I don't understand how we went from the position of actually being quite evidence-based about decisions on school closures to suddenly forgetting all that in early part of 2021. It baffles me.
And if I might ask again a broad question about the approach to the period thereafter, because the inquiry has heard significant evidence about, as a result of Delta and then subsequently Omicron towards the end of the year, Scotland having very significant cases, even in comparison, obviously the infectiousness of Omicron was higher, but the numbers compared to the rest of the UK being highest in Scotland. Scotland suffering a significant mortality almost to the same level as the first two waves in what one might describe as the third wave, and the NHS being driven to the point of procedures having to be cancelled, the military having to be called in to provide assistance. One of the things that we noticed was that from June 2021, the group that you sat on with a considerable amount of expertise sat much less frequently in that period, other than a cluster of meetings around about December 2021. It sat really monthly, we think, from June 2021, at a time when the cases started to rise again as a result of Delta. Do you feel that at that stage, although you've pointed earlier to there being a focus on harm one, that there perhaps was an insufficient focus by that period on trying to control what was going on? Such were the consequences which we've seen.
I do. We're now at that stage learning what living with this virus looks like, and it's not pretty. It's a serious infection. It's causing a lot of disease, some death. It's causing long COVID as well. It needs to be managed. That doesn't mean we have to lock down, close schools again, but it means we do need to manage it. This is not a public health problem that has gone or is ever going away. We're going to need to manage it for the foreseeable future.
And do you think, given certainly the comparative levels of infection and mortality, that it was mismanaged over that period?
It's your word, not mine. I hadn't used that before, but the phrase I use that I don't think we're paid sufficient attention to it throughout there. I mean, of course, attention was reactivated during the Omicron wave, and now we're back to a stage where we're not paying much attention to it.
Thank you. Could I just ask you one further series of questions? You were a member of the Scottish COVID Advisory Group, as we have established.
That's correct.
As a member of that group, or in any other capacity, did you have any means by which you could contact Scottish Government ministers directly?
I don't. I mean, I imagine I could have done if I'd wanted to, but I wasn't. There was no channel obviously set up for me to do that. I could have cold called them, I guess, but I did not do that, and I wouldn't have done it at that time because there was now a formal advisory structure that I was part of.
Did you contact or have any means of contacting any government ministers by email, telephone, or other informal messaging systems?
I never looked to see if I had their email addresses. It never came up. I think I had the First Minister's office email address because we actually, my group did a dashboard that, among other recipients of that, was her office. But so I suppose I could have contacted it through that way, but I didn't do it.
I have no further questions, lady. I'll just check. There are no co-participant questions.
Just one question. I just want to make sure I've got down your evidence correctly, Professor Woolhouse. Going back to the very cautious approach of the Scottish Government to relaxing restrictions, you said that the Scottish COVID Advisory Group were very clear on the other things that could have been done, rather than just being very cautious, which you said wasn't necessary because of the seesaw effect. What other things do you think could have been done as opposed to being very cautious about relaxing restrictions?
So the Scottish Government strategy didn't pay no attention to this at all. It put all its eggs in one basket, as far as I could see, really, which was what we called here test and protect. So, and it didn't prove sufficient by itself, as we saw during the second wave, to really keep on top of any possible resurgence. So there were three. So Scottish Advisory Group wanted to strengthen that, and there were two mechanisms for doing so. First of all, to increase compliance with the need to self-isolate. There was evidence that there was a lack of compliance, so we wanted to do that. I was very concerned about the fact that even in the second half of 2020, in Scotland, we were only finding half the cases. We only knew this because of the Office for National Statistics surveys that started up, but we were only finding half the cases. If we could find the other half, we could obviously strengthen the whole test and protect system enormously. So that was something. I had introduced into the discussion as early as March 2020 that we needed mass testing, and the advisory group repeatedly referred to the potential of mass testing all the way through that summer and into the autumn. It was trialled in England in November of that year, but it wasn't rolled out in Scotland for another year for the Omicron wave, so we didn't do it. And the final thing that we wanted to do was, going right back to almost the beginning of this discussion, was do more to protect the most vulnerable, because Scottish Government never embraced fully the idea that you could do more to protect the vulnerable, and that would just directly save lives. It doesn't matter what else your strategy is. It could be anything. We don't have to argue about the strategy, just the plain fact of if you protect people who need protecting, fewer people will die. And they never embrace that. And yes, that was a big disappointment.
That's not as straightforward as just saying we're going to put an iron curtain around a care home, for example, because care workers move between different care homes and the like. I mean, and they themselves obviously get infected. You have a shortage of staff. So it's not straightforward just to protect the vulnerable, is it?
No, the protection of care homes was better in the second wave, considerably better. So it's not straightforward. So, and you're right, if you want to avoid the harms of restrictions all the way up to lockdown, you have to do the work. You've got to put the effort in. You've got to invest the resources, the time, and most importantly of all, you've got to see it coming and plan ahead. And when we have a government here that in whenever it was, July, August, was talking about zero COVID, they have clearly not got their minds on preparing for future waves that will necessitate these alternative interventions. Their thinking is completely in the wrong direction. So it's not going to happen, is it? No, it didn't. We didn't make the investment in all those alternatives.
So although you accept it wouldn't be easy, you think there are ways if people had put enough effort and planning and resources into it, it could have been done?
Oh, absolutely. And actually, the most effective of these was the mass testing, which, as I've said, I've been advocating for so long. I see that as coupled with a vaccine, which is obviously important, but the reason why we've managed to bring Omicron under control without going back into lockdown, and lockdown was being talked about in that period, but it was the mass testing, I think, that kept us out of lockdown. Well, if we'd introduced it in Scotland and elsewhere in late 2020, when we had the technology, we knew it worked, we wouldn't have needed a second lockdown here. We could have tested our way out of it, but we took another year to roll that out.
Thank you, Lady. There's just one matter I was going to bring up. The Professor earlier talked about email correspondence he had with Dame Sally Davis, which you'll recall led to Dame Sally contacting Dr. Calderwood, and he suggested that we had access to his email to Dame Sally, which indeed we do. Just to read it into the transcript for others who may be interested, the reference is INQ 000352401. Thank you. Thank you, Professor.
Thank you very much indeed, Professor Wallace. I don't know if I can say I'm not going to ask for your help again, but thank you very much for the help you've given so far.
Thank you, Melanie.
Thank you.
The next witness, my lady, will be Professor Stephen Reicher. Mrs. Arledge will be asking the questions.
After me, I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
that
the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
Thank you.
I hope we haven't kept you too long, waiting too long, Professor Reicher. I'm sorry if we have.
Thank you, my lady. You are Professor Stephen Reicher. Yes?
You almost pronounced it correctly.
Almost?
Yes, I am.
Will you do it then?
Please, yes.
Reicher.
Reicher. My apologies.
No.
Good start, isn't it? You've provided the inquiry with two witness statements, one for Module 2 purposes, where you didn't give oral evidence in Module 2, and obviously Module 2A, where you are here today. The reference for Module 2A, dated the 13th of December 2023, is INQ 000370347. That's hopefully come up on your screen in front of you and is a familiar document to you.
Yes.
Page 79, we won't need to turn to it, has your signature and statement of truth. Are you happy that this statement remains honest and true to the best of your knowledge and belief?
It does. I mean, I have done a little homework since and gleaned a little bit more evidence since, but I think it only confirms the broad arguments I'm making in the witness statement.
Thank you. And for reference for those who are interested, we don't need to bring it up, the INQ for the M2 statement is INQ 000273800. You are a professor of psychology at the University of St Andrews, is that right?
That is, yes.
I think you're regularly used referred to in the phrase of behavioural scientist, but as I understand it, that's not a term you prefer.
Yeah, I've never been quite clear what behavioural scientist means, I have to say. I think sometimes it's a term that we like to get science in to make ourselves sound a little bit more credible. I'm perfectly happy with being called a psychologist, and more specifically, a social psychologist.
And as a social psychologist, your primary interest is in how humans interact with one another and in a social setting, is that right?
Yes. I mean, my research has been, on the whole, on group processes and collective behaviour. And so, on the one hand, I've covered a number of issues relevant to the pandemic, issues like social influence, social solidarity, and leadership. Most specifically, I've done work on human behaviour in emergencies, mass behaviour in emergencies. And I think it's that expertise which led me into the weird world of pandemic advisory committees.
And broadly speaking, is it right to say that the science or the behavioural science is a matter of understanding the impact in terms of the context of the pandemic, understanding the impact of human behaviours on how the virus is spreading, and then also how to influence the spread because of the knowledge gained in respect of how it spreads?
Well, the way I saw the advisory committees working was that it is for the medical scientists to tell us what sort of behaviours are likely to spread the virus. I'm not an epidemiologist or a virologist, as will become abundantly clear, so I can't tell you what behaviours are necessary. But once they can say to me, look, these are the types of behaviours that increase transmission, I can begin to think about, well, how might we be able to change those behaviours so as to reduce transmission? So it's very much, to use a medical term, a biological term, a symbiotic relationship where each depends upon the other. We very much depended upon them. I think they also depended upon us.
So to put it in with an example, the epidemiologist will come to you and say, the evidence suggests that the virus spreads as a result of close contact within 15 minutes, within a metre of one another for 15 minutes or more. And you, as a behavioural scientist, to use the phrase you don't like so much, say, well, how do we think about how we influence behaviour? What do we do to make people not stay within a metre of each other for 15 minutes in unventilated areas?
To a large extent, although I would make a couple of points in relationship to that. The first is, I think the whole dilemma of the pandemic, and the reason why it's so difficult, is that the core thing we needed to do was to keep people physically apart at a time when we know that being socially together is critical to human well-being. And early on in the pandemic, in 2020, we wrote a book called Together Apart, I think it's in the evidence, which tried to summarise the nature of that dilemma. We're trying to deal with something that's really, really difficult. And the second thing is, and again, this is going to be critical to the points I shall, I think, be making subsequently, depending on your questions. It wasn't us making people do anything. It wasn't us telling people to do anything. It was how can we engage with the public and jointly do something. And I think as long as we see things in a top-down manner, actually we get things grievously wrong.
Because, and again, sort of applying what you've just said, in times of... humans are inherently social creatures, as it were. Yeah. And no doubt, in times of strain and stress, require more social interaction, or would be expected to have more social interaction and community support at exactly the time when that social interaction was causing illness, the spread of the virus, and ultimately death. And
well, you see, I think that wasn't necessarily true, but I think we made a huge mistake early on in the pandemic when we talked about social distancing, and that phrase became virtually universal. We've got to socially distance. Actually, we didn't have to socially distance. What we had to do was physically distance, because physical proximity led to the transmission of the virus that could kill you. We didn't want to socially distance people. We wanted to keep them together. And the fact we conflated the two, we talked about everything as social distancing, meant that we didn't put enough effort into asking the question, how can we keep people socially together? How can we keep people connected, especially more marginalised social groups during the pandemic? So it wasn't a natural contradiction. I think we turned it into a contradiction by failing to recognise that distinction between physical and social distancing.
When did you start to see that contradiction really coming to the fore in terms of the use of social?
Well, as soon as the phrase was used. I mean, as I say, we wrote a book. Academics are rather slow creatures, as you might have discovered. We managed to write a book in, I think, 2 months because we felt this is such a critical issue, In fact, there is a whole psychological literature which I've been involved in, which shows the importance of social connection, not only for physical, but for mental health. Feeling part of a community, I could go through a long list, and I won't, of the various ways in which it benefits you. So I was acutely aware of this tension right from the start, and a lot of my work has been around how mass gatherings, collective behaviour, which is often seen in negative terms, is actually rather good for us in fostering a sense of community and improving our physical and mental health.
We'll come on during the course of your evidence to sort of specific examples, but we've started down this path a little, so let's continue. So you recognise, or you recognised early on, as soon as the phrase social distancing was an issue, it created its own issue. Was this advice that you were feeding into SCAG and more broadly? Beyond, although I appreciate having written a book, you might suggest it's out there, as it were.
Well, I think the core psychological issue for me was this. I've already made the point that for me, one of the major implications of the pandemic as a whole is it told us behaviour matters. It doesn't just matter at an individual level. It's not just a matter of interpersonal relations. It matters at a systemic and societal and policy level. And one of the first times that people thought of psychology and policy together. But that then raises the question, what sort of psychology do you use? Now, my work, in general and on disasters as well, shows the importance of bringing people together as a community with a sense of shared identity, a sense of we-ness. And often, when you look at the popular representation of crises, there is this notion that we panic. In other words, in a crisis, we act individually, we all rush to the exits, we trample others, and we turn a crisis into a disaster. Actually, the evidence that I've been involved in, my colleague, Professor John Drury, who's also on SPI-B, has been involved in, shows that what tends to happen in a disaster is that you have a common fate, a common experience, and people come together as a community. It's a frail sense, it can be undermined by government action, but that sense of shared community is absolutely critical in the pandemic response in a number of ways. First of all, it means people care for others. The early polling, for instance, showed that the major factor in adherence to measures was wanting to come out of this as a community. And our own research shows the key factor in adherence is not your individual risk, it's the collective risk, it's the risk to the community. So creating a sense of community increases adherence. It increases solidarity in practical terms. We saw that 12 to 14 million people became involved in mutual aid groups, probably more if you include, we've heard a lot about WhatsApp, but informal, street-level WhatsApp groups where people looked out for neighbours. And also that sense of community is good for our physical and mental health. So in a sense, if I had one message, it was don't fear the public, don't fear their frailty, don't see them as a problem. Rather understand that if you bring the public together as a community, and what's more, that they see government as being with and for that community, then the public become an absolutely key resource. They're not the problem, they're the most precious resource you have. And all my interventions, in a sense, was about how do you achieve that? How do you scaffold that? How do you support that? How do you create that sense of community? So this was one aspect of that absolutely key critical message that I was trying to get over in all the various places that I spoke.
Could you speak a little more slowly?
Oh, I'm sorry. That's slow for me.
Oh, was it? I know the feeling I speak too quickly as well.
We have a stenographer who is typing away frantically.
I'm sorry, stenographer.
Could we, in light of what you're just saying about public adherence, could we look at paragraph 63 of your witness statement, please? I think this is what you were taking us through, but I just want to sort of orientate ourselves. And you talk about the sort of how the factors of public adherence to guidance, legislation. We'll come on to that shortly as well. But you say that the factors that have been seen before COVID came along were actively applied. It remained the same in terms of in the COVID response, despite the fact that of course COVID was somewhat unprecedented and rather different, no doubt, to the studies that had been in terms of disasters otherwise, in terms of longevity and acute issues. So you say that the first issue, or the first factor, is risk perception. So by that, do you mean explaining to people and making everyone aware that this is a big deal? People can die, people can become very sick, or is it a broader sense of risk perception in that regard?
So I'm glad you brought up risk perception, because I think it's an absolutely key issue, and I think there's been much misunderstanding of what was said around risk perception. One of the criticisms made of SPI-B and of behavioural science in general is that we wanted to use fear to frighten people into adherence. But there is a huge difference between making people realistically aware of threat so that they can do something about it, and fear, which makes you feel, well, we're doomed, there's nothing we can do.
The equivalent of shouting.
Point is, sorry.
The equivalent of shouting fire in a room but not having fire exits that people can see.
The analogy I often use is, I don't say to my child, the world is a terrible, dangerous place. If you go out, you'll be killed. I say to them, look, there are some real risks out there, like crossing busy roads. So be careful. This is what you do. You obey the Green Cross Code, and you will be fine. So if you give people realistic risk information combined with information about how to mitigate it, actually it doesn't increase fear. If anything, it decreases fear because it empowers people. And the core concept for me here is empowerment. You disempower people either by not telling them what's going on. To hide risks from people doesn't empower people, it disempowers people. And you also disempower people just by talking about threat without mitigations. If you want to empower, you do the two together. And that's what we were saying time and time and time again. You need to make people realistically aware of the threats, because if there's no threat, why should you do anything, right? If the virus either isn't there or can't harm us, why would you do anything, from getting vaccinated to keeping distance or whatever? And there is ample research, both from previous pandemics, the H1N1 pandemic, a lot of research in Hong Kong, but equally within this pandemic, that making people realistically aware is important. Now, if I could just finish by going back to my previous point. If you have a sense of the public as psychologically frail, unable to deal with information, you say to yourself, oh, I can't tell them anything, because they'll panic, right? But if you actually have respect for people and are open with people, and not only give them information, but the wherewithal to deal with that information, actually, you can be really effective. And that's why that general attitude that the public are a problem, the public will panic, gets in the way of doing the things you need to do in order to be effective.
And you say in your statement, I think, as hopefully not paraphrasing too much on this, that the third element, of the third factor, is that social identification. So there's a sense of all in it together, and that is part and parcel, is it not, of we can do something, we can move forward if we're all in it together and we're all pulling for the same team, as it were.
I mean,
is that what you mean by that?
One of the problems of the pandemic generally is people talked in terms of binaries. It's either this or it's that. It's this factor or it's factor. Of course, when you deal with human behaviour, there are always multiple factors. Now, we tend to like lists of 3, so I think I've given you 3 factors there. I'm not saying these are the only factors. However, there was a hugely influential paper, probably one of the most influential papers in the whole pandemic in terms of behavioural science, which was published in Nature on harnessing behavioural science. And there we made the point that when you look at the research on disasters, this sense of shared social identity, of we-ness, is absolutely critical. And Nature has just published an analysis which looks at all the literature that came out of the pandemic, which confirms the importance of doing this. This only came out a month or so ago, so I'm not sure if it's in the bundle. But the point is this, okay? If I am young and relatively healthy, and sadly I'm not that young, but if I'm young and I'll have my son in mind, he might say to himself, if he was thinking individually, look, I might as well go out during COVID, because the risk to me is relatively minor, and the cost of staying in at 18 or 19 with your elderly parents is huge. Okay? So you do the cost-benefit analysis, and you think, well, I might as well go out. If you think in collective terms, right, now not the risks and benefits to myself as an individual, but to the community, I say to myself, if I go out, I might spread the disease, and I might kill somebody who's elderly or vulnerable or whatever. And so the risk calculation flips over completely. So thinking in terms of we, having a sense of this matters to us becomes absolutely critical. And we've confirmed that with a paper published at the beginning of this year, which is that sense of collective identity. And I care about the community. And one of the things that worried me a lot was that as we went through the pandemic, we started off and nearly everybody was saying that. Certainly as we shifted to notions of personal responsibility, we began to help develop a notion of, I'm all right, Jack. And I think that undermined the response. I think it undermined it practically. I think also morally and ethically we were produced a society which is less concerned about its more vulnerable members. And I think that is equally corrosive.
Might an example of that be, for instance, the vaccine passport that you speak of in your statement, in terms of all of a sudden you've got this, you've been vaccinated, so you've got your own thing to prove you're fine, and there is a risk, is there not, in those circumstances of forgetting the collective, as it were? Okay,
so I think vaccine hesitancy, you've gone straight to the heart of it. It's a brilliant example of these issues and allows me, I think, to illustrate them very, very clearly.
Before you go any further, I suspect our stenographer is still going to be struggling, because if you could slow your answers slightly, I'm sorry.
But do help me by telling me to go more slowly.
Thank you.
There are 2 broad ways of which you can deal with vaccine hesitancy. One is to say people don't take the vaccine because they are too stupid or too immoral to care. They're selfish. So you can say there's something wrong with those individuals. Now, the problem with that is that when you look at the figures, the statistics on vaccine hesitancy, they are much larger amongst certain groups, more deprived groups, ethnic minorities, in particular black British people, much less likely to get vaccinated. Now, if you go down that individualistic route, you then come up with conclusions like black people are either less intelligent or less moral than others, and hopefully none of us want to go down that route. An alternative approach is to say it's not about the information itself. It's about our social relationship to the source of that information. Do we trust those who are giving us this information? And there is good reason to understand why certain groups have less trust in government because historically they have been treated differentially. There was a report, for instance, that came out at almost the same time as those statistics came out from the House of Commons, the House of Lords, which showed that 60% of black people felt that the NHS did not take their priorities as its priorities. So the key issue becomes not the intellectual or moral abilities of the individual, it becomes an issue of building trust. And how do you build trust? Well, one of the ways you build trust is not to say there's something wrong with you if you have questions. You should have questions if somebody wants to inject something in your body. It's perfectly reasonable. So you shouldn't treat people in negative terms. You should engage with them. You should have dialogue with them. You should work through their communities. And in fact, early on, we wrote a paper on community engagement showing historically it had been massively successful around the world, especially with minority communities. So vaccine hesitancy shows us some of the pitfalls of that individualist, there's something wrong with the individual, rather than that issue which says what's primary are the issues of social relationships. How do we get people to see government as being on their side? Vaccines introduced for them rather than something done to them. How can we make people see government part of us rather than standing outside and waving fingers at or punishing or bearing down upon us?
We'll move on in a moment to enforcement issues and around legislation, but just coming back to the vaccine passport in particular, because in your statement, I think you raise concerns about paragraph 105 and 106, that the concept of vaccine passports. And I don't want to get into the detail about how it all worked in practice.
Yep.
I'm sure the inquiry will be dealing with that in due course. But what I'm interested in is the messaging surrounding that and how that fed into Scottish government decision making. Because you say in your statement, don't you, that you were opposed to certification. Why was that?
Okay, so again, we published a paper which showed that, especially amongst groups who do not trust government, then vaccine certification increased or gave traction to the anti-vaxxer narrative of they're trying to control us, they're trying to do something to us, and thereby decreased their willingness to get vaccinated. It did have some positive effects. So, for instance, for people who didn't have that distrust, who hadn't got round to it, then if there were going to be consequences, then they might as well do it. What that means is you would more rapidly, in a sense, vaccinate all those willing to be vaccinated. The problem is you would do that at the expense of widening the pool of those who were more resistant to getting vaccinated. So my feeling very strongly was we should focus on engagement. We should focus on working with those communities, on listening to people. There are some very nice examples of that engagement, in fact, from Israel, where in Tel Aviv, they took trucks to the downtown area of Tel Aviv, Dizengoff, and people could come in and they could have a snack, they could have a drink, not alcoholic, and they could get vaccinated. At the same time, they did that in religious communities, but there they didn't give them drinks and snacks, they gave them cholent, which is a stew that religious community. And so once you understand the different communities, what matters to them, how you engage to them, how you go to them rather than wait for them to go to you, you have a hugely effective intervention. And that, to me, was the way to go. Always respect people, listen to them, engage with them. And so it's true of vaccine hesitancy, it's true more generally. Respect people.
You say at paragraph 105 that one of your concerns about vaccine rollout and vaccine passports per se, again, was leading to a sense of invulnerability and loss of caution. Is that, to bring it full circle to where we started this discussion, is that the risk of something like a vaccine passport gives rise to the breakdown in the social identity,
Okay.
as it were.
So there's been a lot of discussion about if you make people safer in one dimension, will they become less safe in another dimension? If you give people a Volvo, which is supposed to be, I'm told, I'm not advertising here, but it's supposed to be the safest of cars, or at least was, do people drive more riskily? So risk compensation is the concept. Actually, the literature nowadays shows that it's not clear there is risk compensation. What is critical is to give people clear messaging about what things do and what people don't do. Now, there is a danger again that if you don't respect people, if you think people are intellectually impoverished, you try and make things terribly simple. You either say a vaccine is perfect, or others say it's completely useless. Okay? Actually, I think the important message is to say, look, a vaccine is far, far, far better than not a vaccine. It does these various things for you, but it still doesn't do everything for you. So you still need to be careful. You still need to keep your distance. You still need to self-isolate if you're infected or whatever it might be. And the danger is, again, it's this general attitude. If you don't respect people, if you have a sense of the intellectual frailty of the public, it leads you to simplify and not do the messaging that you need to do in order to avoid risk compensation.
And how receptive was Scottish Government to your particular concerns in respect of vaccine passports and the risk of anti-vax, all that sort of thing?
In general terms, and I think I've given a number of examples of this, nobody's perfect. We all learn and we all make mistakes. But what is undeniable, I think, is that the Scottish Government did far more, both in terms of this general notion of treating the public with respect and as a partner than the UK government did. And in my statement, for instance, I have compared and contrasted certain statements at the same time by the Prime Minister and the First Minister, showing how, on the one hand, the Prime Minister tends to tell people off and to threaten to punish them. The First Minister tends to recognise the difficulty people have, the efforts that they are putting into compliance, and encourages them to continue with those efforts for the sake of the community. So by and large, comparatively at least, I would say that the Scottish Government did better than the UK government.
You talk in your statement at paragraph 12 in the concept of Scottishness. I'll just allow a moment for this to be brought up. I'm jumping around rather unhelpfully. Thank you. So it's the second half. In the Scottish context, it's possible to draw on the idea we are Scotland because Scottishness is more likely to be, I've lost my, understood in civic terms as including all those living in Scotland and committed to Scotland, whatever their background, while we are England is more problematic, more likely to be understood in ethnic terms, hence excluding those from ethnic minorities. Consequently, the advice as to how to build cohesion and solidarity was different, and indeed I think there's an extra there. In Scotland, I had the pleasure of working with the creatives in crafting public health adverts rooted in norms and values of Scottishness. I'd just like to explore that with you briefly before the lunch break. What do you mean by Scottishness in civic terms, and how that impacted the advice you were giving to Scottish Government and their creatives in the messaging?
That was a very dangerous question to ask an academic. I mean, I've worked on national identity. A number of years back, we wrote a book on national identity and Scottish identity called Self and Nation, available at all good booksellers. And I could talk for a long, long time, but I won't, I promise you. And I'll try and say this slowly. I think there are a couple of key issues here that are really important. Okay? One is a broad conceptual point that when I think about human psychology, I think we are all equally human and the basic psychological processes we have are the same everywhere. But the way those play out is fundamentally different in different contexts, different cultural contexts. Okay, so I am interested both in the general process. I might say that if you create an inclusive social identity, people will support each other within that broad community. But how you achieve an inclusive social identity depends upon the cultural resources and the cultural history that you may or may not have. The second general point, and I have been listening to you on the TV channel, and so I've heard various times people asking, why on earth did we need a Scottish advisory group? I mean, surely, it's the same pandemic, so why did we have to have a different advisory group? And the point is, again, that the context of Scotland is different at a number of levels. People have focused on geography. We are more dispersed. They have focused on comorbidities. We have more comorbidities in various areas, but it's also psychologically different. So when you look at the notion of nationhood, this is too simplistic. People broadly draw a distinction between ethnic and civic nationhood. Ethnic definition is where I come from, okay? By that definition, I personally am not Scottish because I was born in England. My parents came from Russia and Germany and Poland, okay? But if I look to my future and my commitments, right, I can call myself Scottish because I live in Scotland, I'm committed to Scotland, my son was born in Scotland. So civic is very much about your future and your choice over your future. Ethnic is much more to do with where you come from. Now, in England, Englishness historically has been seen as more ethnic. So for instance, far-right groups use the flag of St. George to denote an England which is defined in terms of whiteness. And the empirical evidence shows that ethnic minorities would find it very difficult. Say, for instance, I am Pakistani English. They might say I'm Pakistani Mancunian because they can relate it to a locality, but not to a nationhood. That's not true in Scotland, because over the last 20 or 30 years, and these are balances, I'm not saying it's entirely one way or another, but the balance has moved towards a notion of Scottishness, which is to do with being here and committed to the nation. It's beautifully expressed by Willie McIlvanney when he used the term the mongrel nation of Scotland. What makes Scotland is we're not pure breeds. We are a mixture of all sorts of things. That's what makes us Scottish. So when you say we are Scotland, you include ethnic minorities. You include people who have come from elsewhere. When you say we are England, you are more likely to exclude and create a sense of division. So it's a beautiful example of the social differences and the way in which you can use Scottishness to create a sense of an inclusive social identity, which includes everybody and brings them together, as opposed to an ethnic identity which divides people and which could exclude people, and at worst can even lead to hostility against minorities.
You spoke about Spy. Well, you're a member of SPI-B in the UK setup, as it were, and then you joined SCAG, as we call it, in March 2020, April 2020, just after the lockdown. You joined that. You joined SCAG, I think, as a result of you reached out and said, "Hang on a minute, you're not. I think I can help, and I can bring some expertise." What was your understanding about the Scottish Government and CMOs, etc., using the original title of SCAG? What was your understanding about the Scottish Government's recognition of behavioural science and behavioural management, as it were, in that sort of regard? Is that why you said, come on, I can help, I can bring something to bear here?
I mean, the simple answer to that is I have very little understanding of the workings of government. I've always been an academic trying to understand various processes. I have worked with various groups. My work on crowd behaviour has influenced public order policing, for instance, and I've been on one or two advisory groups about behaviour in emergencies. But by and large, my understanding of the workings of government come more from Yes Minister and Yes Prime Minister than any privileged knowledge. I reached out to Rebecca Widderfield because she was then the General Secretary of the Royal Society of Edinburgh, in which I was heavily involved, but I knew Rebecca from the past, from some of her directorates, talking about, if you like, the behavioural dimensions of environmentalism, resilience, and so on. I passionately believe, and the important message I want to get over is that behaviour matters at that systemic level, and we need to understand that and learn that, both so we can contribute, but also so that we can be involved. And so I knew nothing about the Scottish Government, but I thought if anybody might help in making the case for behavioural science being involved in the debate, Rebecca would, because she had been doing that previously when she'd worked for the Scottish Government.
And when you joined SCAG, you were the only, again, to use the wrong phrase, as it were, behavioural scientist on
it was lonely. It was lonely.
The start. How did you feel your voice was heard in that room, as it were?
There's always a danger if you think you're going to sound as if you're gushing, okay? But one of the things I learned, and I learned many things from my involvement, was how to chair a committee. I think Andrew Morris was remarkable. He included everybody. He wanted to make sure that everybody had spoken. He defined a good meeting. He'd often say, it's been a good meeting, everybody had spoken. He wanted to make sure that everything was covered. And so I got a really strong sense, in part because of the others, because I think people recognise that symbiotic relationship I've spoken of, and it was facilitated both by Andrew and by the civil servants we worked with. I was very lucky to meet and work with such people.
Did you feel like the issue of messaging and the issue of recognising or seeking to influence human interactions and human movements in the context of the pandemic was something that was adequately recognised from the outset?
Okay, so people often, when they think of behavioural science, they talk about communication. Okay, and I think communication is an aspect of it, but I think the core issue was understanding the centrality of positive social relationships, and in fact, and this is utterly key, a social relationship of trust, both within the population and between the population and government. And Andrew used a phrase which I really liked, where he talked about that social contract of trust. And he was aware that that was utterly central to everything we did. I used to say at the beginning, as many people did, that behavioural science will be important until vaccines come along. But I was wrong. The reason why I was wrong is that vaccines achieve absolutely nothing as long as they're in the bottle. It's getting vaccinated that makes a difference. And so as soon as you have a vaccine, you have a new behavioural set of questions, which we've addressed in part. How do you get people to get vaccinated? So it's not as if, you know, the pharmaceutical is primary. It will be the cavalry charging over the hill, after which everything else becomes irrelevant. It's that at every single stage, the behavioural and the medical need to go together, and absolutely key to addressing that is creating that social contract of trust. And in some ways, as I say, that phrase came from Andrew. I think he understood it really well. Now, as to whether others understood it, I don't know, because my experience was in the advisory group. I don't walk the corridors of power. I don't know what ministers say to each other in private, but I do know that within that group, I was deeply impressed by the extent to which it was seen as a community of equals from different disciplines.
Thank you. My lady, would that be a convenient
Yes,
moment?
certainly. I shall return at 1:45.
Grateful, thank you.